Morning, everyone. We'd like to call the Pension Health Benefits Committee meeting to order. The first order of business will be to call the roll, please.
Rob Fechner.
Good morning.
Ramon Rubalcava.
Present.
Margaret Brown.
Present.
Henry Jones. Here. David Miller.
Here.
Arena Ortega. Mona Pascal Rogers. Here. Teresa Taylor.
Here.
Karen Greenross for Betty Yee.
Here.
Thank you. And please note for the record that Mr. Perez, Ms. Oliveras, who else is down there? I can't see. Mr. Ruffino, Ms. Middleton are all here at the dais also. Thank you. Before we begin our agenda item this morning, I want to take a moment to express our deep sadness at the recent passing of Kaiser Chairman and CEO Bernard Tyson. Bernard was a visionary leader, both at Kaiser and within the American healthcare system. He was a champion of quality, accessible, and affordable care, and his influence in the marketplace and his passion for improving health outcomes will be sorely missed. We are appreciative of the partnership between CalPERS and Kaiser that thrived during his tenure. To our Kaiser partners here in the room, I want to extend our condolences, and if there's anything we can do to be helpful to you during this difficult period, please let us know. We also extend our deepest sympathies to Bernard's family and the entire Kaiser community. With that, we'll move back onto our regular agenda, so thank you. Item 2, approval of the timed agenda. What's the pleasure of the committee?
Move it.
Moved by Rubalcava, seconded by Jones. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Thank you. Item 3, executive report. Mr. Molds, Mrs. Lum.
Good morning, Mr. Chair, members of the committee. Donna Lum, CalPERS team member. This morning I have 2 brief updates for you, and they're both related to enhancements that we've made to enhance our customers' experience with CalPERS. The first is related to member self-service responsive changes. I think as many of you know, across service industries, mobile device usage on online transactions continues to grow very rapidly. And we conducted a survey with our user experience team, and what it revealed is that 86% of our members expressed interest in performing MyCalPERS transactions on mobile devices. In response to that, the customer service team, in partnership with the information technology teams, partnered to optimize the existing MyCalPERS website to ensure full usability across all types of devices, handheld devices, iPads, smartphones. Our new design is going to launch on November 23rd, and it does have several new features, including streamlined login process, a centralized location for messages, as well as simpler navigation and ease of reading across a variety of these different devices. The new responsive design also enhances our compliance with AB 434, ensuring that all of our self-service offerings are accessible and functional on small form factor screens, as well as smartphones. So at this time, I'd like to encourage all customers who currently have a MyCalPERS account post November 23rd, if you have the opportunity, to log into your account and be able to experience these new features. And those customers who currently do not have a MyCalPERS account, I also encourage you to go online and establish one. It is an excellent way to perform online transactions with CalPERS. On an additional note, we've also done some rebranding with the MyCalPERS logo. If you recall, it used to have My with a horizontal slash and then CalPERS. Consistent with other parts of CalPERS branding, we've removed that slash there, the upward slash, and now it's simply just MyCalPERS. So again, what I'd like to also do is thank all of the team members that were a part of this redesign, and certainly we anticipate that our customers are also going to be very pleased with the usage of performing transactions on their devices. The last update that I have is centered around new enhancements related to our survey technology in the regional offices. We recently implemented a new way in which members who have come in for any type of appointment at the regional office is now offered the opportunity to take a survey at the conclusion of their session with our team member. Previously, the way that we conducted surveys is we would send random surveys to 1 in every 10 customers that visited the regional office. And with this new technology, we're able to offer the survey to 100% of all of the members that come through. We've had it launched since July, and the feedback that we've gotten so far has been excellent. When we were doing paper surveys, we would get about 13% of the surveys returned. With this new handheld device that our members can use right there in the regional office, we're getting about a 56% return rate right there. The other thing is that we're able to get immediate feedback as opposed to working through all of the paper that it takes to calculate and analyze surveys when they came in paper form. One of the nice things about this is it also does support our initiative to reduce paper. These surveys that we are now doing will save us in about $9,500 in printing costs for the surveys that we used to do by paper. But not only do our customers still have the opportunity to use the handheld device, they also have the opportunity, if they wish to use, we do have some paper cards in the lobby if they want to express additional comments about the service that they received. So we're really excited about this new offering, and again, it's just one other way for us to be able to attain satisfaction level information from our members. And I am pleased to say that from the period of July to September, using this new survey feature, we have achieved about a 99.6% high satisfaction rating for all of the services that are being provided. So, Mr. Chair, that concludes my presentation, and I'm happy to take any questions you may have at this time.
Thank you. Is there no requests? Thank you very much. Microphone. There you go.
There we go. First time. Good morning, Mr. Chair, members of the committee, Don Moulds, CalPERS team. It's great to be here. This is my first committee meeting presenting, and I'm very much looking forward to working with all of you. On our agenda this morning, we have 2 substantive items. The first is a discussion of mental health, and the second is an update on our pharmaceutical spending strategy. Our mental health item continues our discussion from the August committee meeting. As requested by the committee, we have the Department of Managed Healthcare and Kaiser joining us. Second, our strategy on reference pricing prescription drugs has undergone some pretty significant changes since we've talked about it last. I'm going to walk you through those changes, talk a little bit about the why, and talk about how reference pricing fits in with other initiatives that are going to be critical to getting our hands around drug costs. Before we get going, I wanted to highlight a few items from the last month. I'm excited to share that we've hired a new chief for our Health Plan Research and Administration Division, Marta Green. Marta comes to us from the California Department of Managed Healthcare, where for the last 5 years she served as Chief Deputy Director. She has over 20 years of government experience in healthcare and delivery system reform, public policy, communications, and business operations. As chief, Marta will oversee health plan contract management and plan development, clinical programs and appeals, rate development and negotiations, health data analytics, and innovation research. Marta, can you stand and wait? Great. I also want to recognize 3 leaders from within the health branch who have stepped up over the last several months. Vanessa Albritton, who served as acting chief of the Health Account Management Division, Rob Jarzombek, who led the Health Plan Administration Division, and Kim Malm, who led the Health Plan Research Division. Rob and Vanessa will be returning to HAMD to lead that division, and I'm excited to announce that Kim will be staying with the health branch leadership team. Finally, I'm happy to report that we've recently completed another successful open enrollment. The new Search for a Doctor feature within My CalPERS was well received by our members. We had targeted a 10% uptake, and it turns out that 23% of our members who searched for a health plan also searched for a doctor. And 80% of our members reported being satisfied with the feature. We continue to work towards enhancing the new feature to include additional search capabilities such as medical groups and specialists, which will help improve our members' experience and make the tool more valuable. Thank you, Mr. Chair. That concludes my opening remarks. I'm available for questions.
Thank you. Seeing no requests, I appreciate it. Nice to have you here for your first meeting.
Thanks.
I want to take a moment before we move on to agenda item 4 to first of all welcome you all, but thank all of the folks that gathered with us this morning in the stakeholders meeting. I think that was a great time to be able to mingle, sit and talk about issues that aren't necessarily on the agenda, but to get to know one another on a different level. So thank all the stakeholders that joined the board and the staff this morning. And I also want to take a second to introduce a longtime CalPERS staff member who's retired for a few years now. Brand new grandpa, so he's not as awake as he used to be, but Ken Marzion, he was our interim CEO for a couple of years. Welcome, Ken. A new grandchild slowed down his golf game a little, so a little challenging. All right, moving on to agenda item 4, action items. What's the pleasure of the committee? Moved by Taylor, seconded by Brown. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Agenda item 5 is the information consent items. You'll notice that 5A is the annual calendar review, having no request to pull anything off the agenda, but I do want to tell you that there are copies of the agenda there. But yesterday in the Board Governance Committee, the chair of the committee, president of the board, gave direction to both the CEO and the chair of the committee to work together to look at whether or not we need to add more meetings next year on top of this agenda item. So just so you know, we're keeping our fingers on the pulse, and if we need that, we will add additional meetings. So moving on to agenda item 6A. Mr. Moulds.
Great. Thank you, Mr. Chair. Don Moulds, CalPERS team. I want to briefly introduce our agenda item on mental health. Thanks to the board for their continued interest in the topic. Mental health is getting more attention these days, but the importance of good mental health is still grossly undervalued. In addition to the obvious connections to well-being, everything we are learning these days makes it clear that there is a tight relation between mental and physical health. And every day we learn more about how untreated mental health conditions add to the cost of treating physical health issues, particularly chronic disease. I'm going to turn it over to Dr. Julia Logan, CalPERS Chief Medical Officer, who will be here talking more about the internal work she is leading on mental health. After Dr. Logan, we're going to hear from 2 guests from the Department of Managed Healthcare, Shelley Rillard, who is the director at DMHC, and Dan Southern, who is Deputy Director for Plan Monitoring. After DMHC, you'll hear from 2 representatives from Kaiser Permanente, Dr. Dawn Mordecai and Cynthia Striegel. Before I turn it over, I want to highlight one related bit of work that I'm particularly excited about. Over the last few months, we've been meeting with Covered California to identify common goals and, more broadly, ways in which we can partner with each other. Together, we serve about 3.5 million Californians, so teaming up on common goals can be very powerful. Our discussions have surfaced a common interest in improving mental health. As a first step, we've agreed in principle that we should have common measures for tracking plan performance on mental health and have started discussions about how we can tackle critical issues like better integration of mental health and primary care. Together, we've started talking with national experts on mental health and measurement to review and improve the way we do this. In the coming months, we'll be reporting on how this work is going. With that, let me go ahead and turn it over to Dr. Logan.
Thank you, Don. Good morning. Julia Logan, CalPERS team member. Today, I'll be providing you an update of our activities around mental health since we last met 3 months ago. But first, I wanted to take a moment to thank you all for shining a light on this topic and for asking the questions that really matter and that help us understand the opportunities we have to improve mental health for our members and for all Californians. It has certainly allowed us all to talk openly and frankly about a topic that has too long been in the shadows. I also wanted to thank my colleagues here at CalPERS. After our August meeting, many employees shared with me their own personal stories and expressed validation, and were glad that we were talking about mental health candidly with our board and with our health plans. To those folks, I appreciate your courage. To orient you to our time together this morning, this presentation will have 3 parts and mirrors many of your requests from our discussion in August. First, we will update you on our activities and newly forged partnerships around mental health and discuss our approach to monitoring quality mental health. Second, Shelley Roulard, the Director of the Department of Managed Healthcare, and Dan Southard, Deputy Director, Office of Plan Monitoring, will provide an overview of the department's role and strategies to increase timely access to mental health services and how they determine network adequacy. And last, Dr. Don Mordecai and Cynthia Strigel from Kaiser Permanente will provide a mental health and wellness update using a standard set of guidelines that CalPERS team members put together based on your feedback. These guidelines will be used by plans when presenting to you and are included as an attachment in your agenda item. The guidelines include questions such as explaining strategies that each plan is using to ensure CalPERS members receive the right mental health care at the right time. Each plan will present on initiatives to address stigma and social drivers of health, which are environmental, socioeconomic, and other factors that affect health, and how they're evaluating the impact of these two, and how each plan is integrating mental health with primary care. There are so many clinical studies that have shown benefits to the integration of mental health, including improved outcomes, improved access, and decreased stigma. 1 in 5 primary care visits involves a mental health issue, and I can certainly attest to that in my own practice. Yet our healthcare system struggles to integrate the two. Those are a few of the topics that the plans will address. I am hopeful that it will inform you and our CalPERS members on where we are and where we need to go to improve mental health. Kaiser will be our first plan to present, and the other large health plans will be presenting to you next month using the same set of guidelines. So that's something to look forward to as well. This slide reminds us that mental health includes emotional, psychological, and social well-being. It affects how we all think, feel, and act in our personal and work lives. And I know you know this, but I wanted to reiterate how common mental health issues are. Nearly 1 in 6 California adults experiences a mental illness of some kind, and our children are not immune. 1 in 13 children has an emotional disturbance that limits participation in daily activities. I'm sorry, I skipped. Okay. There can be significant barriers to receiving the right care at the right time. Californians can face fear of rejection about mental health issues. In fact, 8 out of 10 workers with a mental health condition say shame and stigma prevent them from seeking treatment. Other barriers include workforce limitations, trouble reaching providers far from home, and limited screening in clinical settings for depression, anxiety, and substance use issues. And because of all these, only a third of people with mental health conditions gets treatment. In August, we reported on the prevalence of the most common mental health conditions among CalPERS members. And as you remember, depression, anxiety, and neuroses ranked 1, 2, and 3 respectively for both basic and Medicare members. You asked us to report the numbers behind these percentages. As you can see, more than 50,000 basic members and 12,000 Medicare members had a claim for depression in 2018, and smaller numbers of people had claims for anxiety and neuroses that year. One of our stakeholders astutely pointed out in our stakeholder meeting last week that these numbers seem low compared to the prevalence in the general population, and that is true. According to the Let's Get Healthy California initiative, almost 18% of adults reported in 2017 that they had been told they had depressive symptoms. The difference in our rates versus what is reported elsewhere is in part because our data comes from our data warehouse. It's our claims data and reflects only those people who have a medical claim, such as a visit or treatment for one of these mental health diagnoses. So it's important to keep that in mind. And that's also in part why we are looking at other ways of measuring mental health issues, and I'll discuss that in a minute. The CalPERS team has been engaging the plans through our quarterly business reviews, ad hoc meetings, and regular meetings with our plan medical directors and other plan leaders. We address strategies to improve mental health care and best practices and programs that we could potentially scale up across our plans, including how to incorporate effective telebehavioral health into our common set of tools for addressing mental health barriers. We've also learned from Kaiser about a skills-based experiential training program that they've implemented system-wide called Mental Health First Aid for the Workplace. It teaches employees how to become aware of and support an individual who may be experiencing a mental health or substance use issue and help them access appropriate resources. Seeing the success in their own organization, they are now offering it as part of their community benefit. In fact, a few months ago, representatives from 17 CalPERS agencies attended a training. I will also be participating in the course next month to learn firsthand if it could be something to roll out more broadly. As Don mentioned, we have been doing a lot of thinking on how to measure high-quality mental health care and our approach to ensure our members are receiving the right care at the right time. To do this, we've been reaching out to our partners here in California and experts nationwide to collaborate and leverage our collective impact and voice. We know that our impact will be much stronger and long-lasting if we work together. Between Covered California, CalPERS, and the Department of Healthcare Services, we are talking about a really large voice, the purchasing power of more than 17 million Californians with overlapping provider networks and health plans. Covered California is currently undergoing an overhaul of their performance and quality measures in their contracts. So we are participating actively in those discussions and have partnered with Covered California on integrating mental health and primary care as well. We're also learning from other partners and colleagues at the Integrated Healthcare Association, the Pacific Business Group on Health, and Smart Care California on what works and what doesn't work. We are especially interested in measuring how well care is integrated and how mental health care works to improve outcomes rather than just measuring the process, especially in those who have co-occurring physical conditions that can become so much worse with a mental illness. We will be sure to keep you updated on our progress around measurement. I am also pleased to report that we have made changes to the Health Plan Member Survey for 2020. This is the annual survey given to a sample of CalPERS members to track experience and access to care. The 2 previous questions on mental health were replaced with 6 new validated mental health questions from a survey called the ECHO survey that provides more details about non-urgent mental health appointment access, urgent mental health service access, and how members perceived improvement after receiving mental health care. Our goal is to use the results from these questions to evaluate, monitor, and improve the quality of mental health services for our members, and to break these results down by health plan when possible. We realize the importance of good mental health and wellness in the workplace. So we are taking advantage of this wonderful opportunity to commit to CalPERS team members and are working together with a statewide employee assistance program and our own human resources colleagues to increase awareness of mental health issues and promote wellness enterprise-wide. The Employee Assistance Program is such a valuable resource and empowerment tool for not only CalPERS employees, but all state employees. And we've been working to educate our team members about the free and confidential resources available to them. This includes a new service called Messaging Therapy, which is therapy through secure text messaging. I mentioned in August that our governor is also prioritizing mental health wellness for our Californians. In his first budget, he allocated almost $11 million to fund a statewide warm line, which offers emotional support and resource referrals for people who are experiencing mental health challenges. This California peer-run warm line launched last month, and the call center expects to receive about 25,000 calls a year. This lower level of care can be vital for people who want to talk to someone about their feelings but don't feel that they need a crisis line. Please feel free to share this valuable resource. Oops. I will conclude my part of the presentation today by reminding us that overcoming stigma is everyone's responsibility. I truly appreciate the efforts that you have all made to support our CalPERS members. That ends my portion of this presentation, and now I'll turn it over to Shelley and Dan from the Department of Managed Healthcare.
Before you go forward, we do have one question. Ms. Green-Ross?
Yes, so I just wanted to thank you for the information about the changes to the customer survey. But just wondering, based on what you mentioned prior to that, when you had polled this in the stakeholder meeting and mentioned that a lot of people don't report or complain or comply because of fear of stigma. And so I'm just curious if we would do anything sort of a little more proactive to poll the stakeholders and or members to get a better read, because not everybody fills out the survey because of the stigma issue. So just wondering about that issue with the survey results, so we can really get a handle on whether our members are suffering issues with access.
Yeah, so,
Timely access.
and that's a great question. So we can't always get all of the information we need from one particular data source, like our data warehouse. So we use different sources of information to gather as much as we can about how our members are using mental health services and if they're getting the right care at the right time. So the member survey is one tool, but there are different ways to understand that more broadly, such as performance measures and our data warehouse.
I'll just add that part of as Dr. Logan mentioned, we use a couple of different sources: claims data, surveys. Part of the purpose of these calls that we've been having with national experts is to talk about other possibilities, other ways of getting this information, both on questions about access and about quality. So that's part of the work that's ongoing at the moment. The goal is to supplement that information.
Thank you. Appreciate that.
Thank you.
Okay. Hi. Good
Hi.
morning.
Morning.
I'm Shelley Roulard. I'm the Director of the Department of Managed Healthcare, and I'm really pleased to be here today. I thank you for inviting us to present on how the department monitors timely access to care and health plans compliance with federal and state mental health parity laws. Before I get started, I just want to comment about your new hire. She's fantastic. I miss working with her, but she's going to do a great job for you here at CalPERS, and you're lucky to get her, so congratulations to you. I did take the opportunity to read the transcript from your August meeting to get a sense of Dr. Logan's presentation, and she did a great job in presenting the challenges and innovations in addressing mental health concerns, and again, I appreciate your interest in this issue. As she noted, access to behavioral health care services is a very high priority for our governor and for the Secretary of the Health and Human Services Agency. The department has been working hard to ensure health plans comply with all requirements regarding timely access to care and federal and state mental health parity laws. I thought this morning I would do just a high-level overview of the department's work, and I'll talk a little bit about our monitoring of timely access to care, and then Dan will talk about the federal and state mental health parity compliance work that his team has been doing. So the mission of the Department of Managed Healthcare is to protect consumers' healthcare rights and ensure a stable healthcare delivery system. We are a consumer protection agency first and foremost, and we take that responsibility very seriously. Our authority comes from the Knox-Keene Healthcare Service Plan Act of 1975 and all of the amendments after that. Right now, the department regulates 125 health plans, including 78 full-service health plans. That includes most of the Medi-Cal managed care plans, and 47 specialized health plans, and those are like dental, vision, behavioral health plans. Over 26 million Californians are enrolled in health plans regulated by the department. This represents 96% of the commercial and public health plan enrollment in California. I would note here that the department regulates 7 of the CalPERS health plans. We offer 11 different products to your members. We do not regulate your self-insured PPOs, PERS Choice, PERS Care, or any of the association health plans. Those plans are not subject to the Knox-Keene Act, and the department has no jurisdiction over them. Similarly, while we license Medicare Advantage plans, our oversight is limited to monitoring those plans' financial solvency. All other aspects of Medicare Advantage plans, such as covered benefits, utilization management, and provider networks, are the purview of CMS. Importantly, the department offers a consumer help center where individuals who are having problems with their health plans can come and get assistance in resolving those problems. This includes anyone who's having problems getting a timely appointment for health or behavioral health care, who's had needed care delayed or denied, or who has received a bill for services that the health plan should have covered. The Help Center also administers the independent medical review process, where independent doctors and other providers who are not affiliated with a health plan will review a health plan denial of service to determine if the service was medically necessary. And if the independent reviewer determines the service was medically necessary, then the health plan must provide it. Consumers who file an IMR end up receiving the denied care about 62% of the time. So moving on to an overview of timely access. Under California law, health plans are required to make sure that consumers have ready access to all services covered under their health plan contract. For this to occur, consumers must be able to see a health plan doctor and other plan providers within a time frame that's appropriate based on the consumer's clinical condition. To ensure access to care, health plans must maintain networks of providers who have enough appointment availability to meet the needs of all plan members. Providing timely access to care is a fundamental duty of health plans to their enrollees. So the department monitors health plans to ensure that all networks have the right types of doctors, including specialists, and other types of providers, such as non-physician mental health providers, that would be therapists, psychologists, or qualified autism providers. We ensure that the networks have enough providers to serve the overall plan population, that providers are located within reasonable distances from where their members live or work, and the providers have enough appointment availability to meet the requirements of the timely access laws and regulation. As I said before, ensuring access to care is a high priority for the department. And we use a variety of regulatory oversight tools to ensure consumers have timely access to care. The timely access regulation requires health plans to submit annual reports detailing compliance with the time elapsed standards. We are currently finalizing the timely access report for measurement year 2018 and expect to release it sometime next month. We also analyze consumer complaints and the independent medical reviews that are filed with the Help Center and how they are resolved. We track and trend those issues to determine if there are any patterns of particular issues or patterns with a particular plan that need to be addressed. The department also evaluates health plan networks to make sure they meet the geographic and provider to enrollee ratio requirements. We conduct surveys or audits of health plans to ensure they're meeting all the requirements of the law and are following their own policies and procedures with respect to timely access and network adequacy. And they do file those with the department, and we approve them. Last but not least, we take enforcement action against health plans that violate timely access requirements. And with all our enforcement actions, the goal is to change plan behavior and bring them into compliance with the law. Since 2013, the department has taken a number of enforcement actions that include violations of the timely access regulation, with fines totaling almost $7 million. Most enforcement actions also include corrective actions that the plan must take to address whatever the deficiencies are. I'd like to reiterate, the department's Help Center is a resource for anyone having problems with their health plans. Even though we don't have jurisdiction over some of the CalPERS health plans, if a CalPERS member calls us, we can direct them to the appropriate community resources. And we also have a fact sheet on timely access to care that's available on our website for folks who want to know more details about the law. So I'm going to turn it over to Dan now to talk about mental health parity, and look forward to your questions at the end. Thank you.
Good morning, Mr. Chair and members of the committee. As Shelley indicated, I'll be talking about how the department has ensured health plan compliance with mental health parity. Before I get into the details of how the DMHC has ensured health plan compliance, I want to talk generally about mental health parity laws. The Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act of 2008 is a federal law that generally prevents group health plans from providing more stringent requirements for mental health or substance use disorder benefits as compared to medical surgical benefits. In 2010, with the passage of the Affordable Care Act, these protections were expanded to enrollees within the individual market. In addition to federal law, there are two applicable California health and safety codes, 1374.72 and 1374.76, which permitted until January 1, 2016, the DMHC director to issue guidance to healthcare service plans regarding compliance with mental health parity. Now, getting into the details of how we've assessed mental health parity and continue to assess it, we approached this initially through a two-phase approach. The first phase was completed by our Office of Plan Licensing. It required health plans to submit documents to the department for review and approval. These documents were related to their benefit designs, cost sharing, and utilization management. Upon multiple back and forths with the health plans, we ended up approving these benefit plan design documents, and we moved into the Phase 2 review for mental health compliance. Phase 2 was completed by my shop in the Division of Plan Surveys, and where we went out on-site or did desk-level reviews of health plan documents and to determine compliance. Those documents included files from the health plans as well as their delegated medical groups, also cost-sharing benefit plan design documents, and how those were applied in real-world situations. The results of those on-site focus surveys were, we found 11 plans to be compliant with MAPIA. 14 health plans were found to be non-compliant in either the area of non-quantitative treatment limitations or quantitative treatment limitations. Those were 2 plans, or both non-quantitative treatments or quantitative treatments, which are 5 plans. Now, a little bit more detail on quantitative and non-quantitative. Non-quantitative treatment limitations are specific to the scope and duration of benefits. An example would be that in a acute care setting, that a health plan would authorize services at a lesser duration for a mental health or substance use disorder than they would for a medical surgical disorder. So it's applying a more stringent requirement on the medical or the mental health substance abuse disorder than compared to the medical surgical side. Quantitative treatment limitations are specific to the financial requirements. An increased cost sharing, copay, deductible is applied inappropriately to the mental health substance use disorder when compared to the medical surgical benefits. When the department found that health plans were non-compliant with a quantitative treatment or the financial requirements, we required the health plan to go back to January 1, 2016 and remediate any claims and reissue or issue reimbursement to all enrollees affected. This resulted in 5,099 enrollees affected and a total reimbursement to enrollees of $517,375.90. We published these mental health survey reports on our public website, and any plans that were found to be non-compliant at the final report, we are in the process of doing follow-up survey to ensure compliance. Any health plans that are found to be non-compliant at the follow-up survey process will be referred to our Office of Enforcement for further review and investigation.
Thank you. Seeing no other requests to speak, I thought we were getting a question, but it looks like not. But thank you very much for the presentation. Oh, there we go. Hold on now. Mr. Ruffino.
Thank you, Director, for your... Am I on? Mm-hmm. Thank you for your presentation. Just quickly, you mentioned your enforcement actions, and you mentioned, there's fines, and you have collected up to $7 million and corrective action. Can you comment on the corrective actions in terms of what's typically reasonable? Is it for a plan to comply? Does it take 3 years, 4 years, 5 years, infinity, or as long as somebody's keep on paying the fine, they can extend a corrective action? Can you just kind of give us a sense the average corrective action, the expectation of time, and the type of actions that you request or you demand?
Okay, thank you, Mr. Ruffino. There's no kind of average or specific time frame for the corrective actions. It really depends on what the violations are and how long we think it's going to take the plan to correct them. Sometimes it involves, like in the case of timely access to care, contracting with other providers or making providers that are not contracted available when somebody needs a service that is not readily available in their area. So we monitor that through the plan survey process that Dan oversees. Our enforcement office also gets regular reports from the plans on how they're making progress. And if they're not making the progress that we feel is important or that has been agreed to, then we can take additional enforcement action against them. So it's really it's specific to each particular action and plan and what the issues are related to that.
But it can take 6 years or
Well,
5
sometimes
years?
it takes a long time. So I'll give you the case of the Kaiser, okay? So we had a 3-year settlement agreement with them that we entered into in July of 2017. So we're coming up towards the end of that period of time, and we will be assessing, well, we have been assessing and monitoring their compliance with that. So again, that was a significant violation that they had, and so it does sometimes take a while for that to occur. Most of the corrective actions aren't that kind of time frame. I would say they're probably less than a year. And then, as I said, Dan's shop goes out and checks to make sure that they've done all the things that they said they're going to do.
Thank you.
Thank you. Ms. Green Ross.
Yeah, I just had a follow-up question to Frank's question on the on this Kaiser outside monitoring process. You've been in there, as I understand, for about 3 years now. Can you tell me just a little bit more detail on what the outside monitor does? Do they just hear from Kaiser as to what they're doing, or do you guys does the monitor actively go in and try to see if the access is there and available for the patients who seek treatment and are getting it? I mean, how just explain how that works, how the monitor is working, and how are you seeing improvement?
The monitor is working with Kaiser on a regular basis, and they are helping Kaiser comply with the terms of the settlement agreement. And that, if you're interested, that settlement agreement is available on our website. They are working closely with the plan, and I think I'll leave it to Kaiser to tell you how well they're doing with that. But I do get regular updates from them and the plan on how Kaiser is performing. To date, Kaiser's met all of the benchmarks of the health plan and of the settlement agreement and the milestones that we've set for them. And because it's kind of an ongoing investigation and enforcement action, I can't really get into a lot of detail about what the findings are at this point.
And I appreciate that. I just was trying to understand if it's Kaiser self-reporting or the monitor does their own sort of through a patient investigation. Just because we've been, our office was reached out by, some groups that have contended that the patients still aren't, it's still taking too long to get in to see somebody. And as you can imagine, as you know, mental health situations can be very delicate and dangerous for certain people in certain situations. And if they can't get in to see a doctor and the right doctor right away, that's very, very dangerous. So,
right.
Is the monitor is it Kaiser self-reporting, or is it actively, proactively looking at it from the patient perspective?
The monitor is actively engaged with Kaiser on these issues. We do also know that there are instances where people aren't getting timely access to care. I will just reiterate again that our settlement agreement deals with Kaiser's quality assurance program, and so when there's a problem, they need to be able to address it, to identify it first and address it, and that is one of the elements of the milestones and the benchmarks that they're making. So we do get reports from the monitor on how Kaiser is doing with respect to their compliance with the settlement agreement. I'll just comment in terms of access to mental health generally. That's an issue across all the plans. I mean, there's not enough providers in the state of California to serve all the needs at any moment. But we're working to try to make sure that the most critical issues are addressed quickly, and that's part of what that settlement agreement is about.
Thank you. And then I have one last question. As you mentioned on the settlement and the claims from the financial end, that the reimbursement through the plans, did CalPERS cross-reference, and were our members impacted, and did we get reimbursement for our members under that penalty assessment process? That's more like for Don or somebody in the CalPERS health benefits office.
We can get back to you with numbers on that.
Thank you.
Yeah, we didn't break that out by who the membership was from. We could go back and take a closer look at that and work with Dr. Logan and Mr. Molds on that to determine of that 517,000, how much of that was specific to CalPERS members.
that'd be great to know. Thank you. Thanks, Rob.
Thank you. Seeing no other requests?
Thank you, Mr. Chair. Now I'll pass it over to the Kaiser team.
Just a second, we have one more question. Mr. Ruffino.
Thank you, Mr. Chair. Before we go there, a quick question for CalPERS staff. Last month, the CDC issued a report indicating the suicide rates among teenagers has tripled since 2007. Furthermore, we see more evidence that there's significant danger between mental illness and medical illness. So is the CalPERS staff tracking these patterns among youths and adults in California? What pattern do you see? And lastly, have the contractor health plans provided sufficient treatment to address mental illness at an early stage?
Yes, thank you for that question. At our August board meeting, we did present about suicide rates climbing in California and specifically among younger people, and we are certainly concerned about that. And that is one reason why we think it's really important to integrate primary care and mental health, and why early intervention and treatment and also screening is incredibly important. So those are the things that we're working, as Dr. Moltz mentioned, that we are working on with experts and our partners with Covered California and Integrated Healthcare Association to be able to understand that throughout California, and then to be able to monitor and improve it within our population.
Can I just do a quick follow-up, Mr. Chair?
Yes.
If these patterns continue into the future, what cost implications will they have for CalPERS? And what implications will they have for the health outcomes of CalPERS members?
They could have very significant negative impacts, for sure. We know that people with serious mental illness die earlier, up to 25 years earlier, so that is something that we are continuing to track and to try to better understand so that we can improve. But yes, I agree, it's a very serious problem.
Thank you, Dr. Logan.
Thank you. Please continue.
Thank you, Mr. Chair. Now we'll go ahead and turn it over to the Kaiser team.
Okay, thank you.
On my mic?
Yep, it was, now it's off. There you go.
All right. Good morning.
Morning.
So thank you, Mr. Chair and members of the board. My name is Cindy Strigal. I'm Vice President at Kaiser Permanente. It's good to be with you again today. I also have along with me Dr. Mordecai to co-present with us today. We're here today as a follow-up to the August board meeting. We deeply appreciate the time today to engage on this important topic. This particular topic is of great importance to our organization and our leadership. It was also a passion of our late CEO, Bernard Tyson. I would like to express my gratitude for the thoughts and condolences we've received as our organization grieves and transitions with this significant loss, especially with your comments in the opening today. Greatly appreciated. Our objective today is to answer the questions provided by the CalPERS staff and those asked during the August board meeting. As has been the case for the past year, we are currently in contract negotiations with one of our union partners. We will do our very best to answer questions based on this situation. To begin with, I'd like to have Dr. Mordecai introduce himself and begin the presentation.
Good morning.
There you go.
Good morning. I'm Don Mordecai. I'm the national leader for mental health and wellness for Kaiser Permanente. I'm a child and adolescent psychiatrist and adjunct clinical professor at Stanford University, and I see patients at the Kaiser Permanente San Jose Medical Center. I'm going to hand that to you,
Yes,
Cindy.
please.
I also wanted to thank the chair for his words about Bernard Tyson. It is indeed a great loss to our organization and really to the nation. Mr. Tyson consistently talked about things that maybe healthcare CEOs don't talk enough about, equity and health outside of the walls of hospitals, in communities, and he cared a lot about mental health and wellness, so I will miss him particularly. As has already been referred to, we're facing a crisis in our nation with respect to mental health and addiction care, with ever-increasing demand and a workforce that is not growing fast enough. As the board probably knows, a recent California healthcare workforce commission found that if demand keeps up as it's going by 2030, California will only have half the number of psychiatrists estimated to be needed, and a third less, or approximately a third less, of the therapists estimated to be needed. Kaiser Permanente has been working to address this situation on behalf of our members through large-scale hiring, creating new approaches to provide rapid access, training hundreds of MD and therapist mental health and addiction care specialists every year, with plans to greatly expand that number. And of course, some of those specialists do come to work for us, but many go out into the California community to serve other citizens. And we have been contracting for external services, and we're building quite a bit of office space to the tune of several $100 million worth, so that our new providers have places to see patients. We have an integrated system which allows us to address mental health and addiction issues for our members across the continuum, from primary care through specialty care. And as this slide illustrates, we provide an extraordinary range of integrated care for our members.
In the August board meeting, one of the questions that I think fits in this slide that was raised was the number of the growth of our therapists in relationship to the growth of our membership growth. Today, when we've pulled the latest information, so we've grown our therapists since, and specifically the question was since 2015. So we've grown our therapists collectively about 30%, a little over 1,200 full-time therapists or clinical care providers in that time frame. At the same time as our membership growth has been about 20%, slightly over 20%, 1.5 million members or so. So it was a question asked in the August board meeting. We've also continued to actively recruit for additional behavioral health staff and currently have 300 positions posted and in the hiring process, recruiting process, I should say, across the state of California.
So Cindy was referring to hiring for specialty providers, but we don't believe that the situation facing our country can be solved in traditional ways, depending just on specialty mental health and addiction care system capacity. We do believe there's a solution. Our strategy is to invest in our whole continuum of integrated care for mental health and addiction, because the demand cannot be met solely in specialty care. We're also making investments upstream, and I'll talk more about this in a bit, to try and prevent the emergence of mental health and addiction conditions by decreasing adverse childhood experiences and making schools trauma-informed. We hope to reduce the stigma attached to these conditions, which prevent people from seeking care. In the area of care delivery, there needs to be a tightly coordinated set of services across the continuum to get people to the right level of care at the right time. These services include rapid assessment and the ability to start people quickly on the right care path based on their diagnosis and treatment plans created by physicians and therapists. Expanded capacity for collaborative care in primary care. This is an evidence-based approach to population care for mild to moderate depression and anxiety. Expanded capacity in specialty care, as we were just discussing, and use of measurement-based care to ensure measurable and meaningful outcomes to our members. Use of intensive outpatient programs and case management for the most severely ill. Use of evidence-based digital tools and telehealth, which can expand care options for members. The ability to move seamlessly along this continuum is important as needed so that you can intensify or moderate the level of care based on a patient's specific needs. And finally, expanded training of mental health and addiction care professionals, as I referred to earlier. Across the state, we train hundreds of mental health professionals every year. As an integrated care system, we are uniquely capable of building this tightly coordinated system of care, which we believe is necessary to actually address the issues facing our nation in mental health and addiction care. It is worth noting that KP Northern California and KP Southern California are the only plans in the state to receive the highest rating for behavioral and mental health care, 5 stars, from the California Office of the Patient Advocate. However, we are not perfect, and we have much more to do making investments and improvements, and we intend to do that.
An additional question that was asked of us in August was the number of days between visits after the first initial. So an insight around the follow-up care and the averages as such. It's difficult in these scenarios because our approach to mental health care is similar to our approach to specialty care. So there's not a one-size-fits-all on how a follow-up visit would be obtained. Our approach is to follow a treatment plan. So just as you would with your cardiologist or OBGYN, there's a need based on your specific care. And so our focus is on following the treatment plans that are developed by those clinicians working directly with the member. Each patient would, their course of diagnosis and need would be different, their follow-up needs would be different, and so our focus is primarily on following the treatment plan.
I might just add that when I'm seeing patients at San Jose, I have some patients that when I see them for the first time might need to go right into an intensive outpatient program, and therefore I need access to that kind of program, which I have. I have some patients who I might start on a medication, say for depression or anxiety, and I need to check in with them in a week or 2 weeks. And I say to them, how do you want to do this? Do you want to do this by phone? Do you want to do it by email? If they need to come in, I'll find a way to bring them in. Most often they're happy to do it remotely, so we make it more convenient for the members. And then sometimes I have very stable patients that I might see once every several months because they're fine, they know how to reach me, and I know that they'll reach out to me if they're having difficulty. So,
Thank you.
Should I go on? Okay. So specifically about specialty services, we are expanding access, as you've already heard. So along with developing this integrated continuum of which specialty is a part, we are hiring many more mental health providers, as Cindy detailed. We are contracting with external providers. We are opening new offices. So we are accelerating a multi-$100 million building project to make sure that we have appropriate treatment facilities. So for example, we are opening a new outpatient mental health and wellness center in San Leandro and Fremont, adding 100 new offices where mental health providers will treat patients, as well as an 18-bed med-psych inpatient facility in San Leandro. And that's a shortage. There's a general shortage of beds in California for inpatient facility, but med-psych is sort of a super specialized area where we were finding that there weren't enough beds for us to contract out for, and so we're building our own. In 2018, we opened a new mental health treatment center in downtown Sacramento. As I mentioned, we're developing ways to accelerate patient access to their initial treatment through programs that more quickly connect members to clinicians. We're expanding our telehealth services. We did, I believe it was about 400,000 telehealth mental health visits in 2018, and we're continuing to expand that. We have developed a mental health service line to help members address issues related to mental health appointments non-urgently. If there's urgent, they need to call into their local clinic or go to the emergency room where we're happy to see them. But for non-urgent issues, we've developed a mental health service line. And then, as I said about training, we're investing tens of millions of dollars to expand our training programs and expand training opportunities for our current staff. There were questions about primary care, so I wanted to address that somewhat. In primary care, we proactively screen high-risk groups like those with chronic illnesses, pregnant women, and those where there's a high index of suspicion for a mental health or substance use condition. Mental health professionals are readily available to primary care providers for consultation. That's one of the advantages of our integration. Primary care doctors are equipped to care for mild to moderate depression and anxiety and can easily refer to specialty mental health and addiction care when needed. A shared electronic medical record allows primary and specialty care physicians to communicate easily about care for a patient, and that's something I particularly value about practicing within Kaiser Permanente is when I have patients with comorbidities, and they can be quite complicated sometimes. It is quite easy for me to communicate with their endocrinologist or nephrologist or cardiologist about their medical situation so that we can coordinate their care. We track data such as access, satisfaction, outcomes, and quality related to our primary care services. All right, so switching gears a little bit, there were questions about the social drivers of health or social determinants of health. We sort of like the word drivers because it's a little less determinative. We don't want to communicate that if you had these situations in your life, you're definitely going to have negative outcomes, so we call them social drivers. This is part of what I mentioned before about how we're working upstream in terms of not waiting for people to develop mental health conditions, but actually trying to prevent them. And this is something that Bernard cared quite a bit about, I would say. So for the past 70 years, part of our mission has always been to improve the health of our members and the communities we serve. As part of our community health strategy, we're committed to addressing the social drivers of health, which are the conditions where people live, grow, play, that impact their health outcomes. Some of our efforts include community investments. In May of 2018, we announced a $200 million impact investment to address homelessness and create affordable housing. We committed to housing over 500 Oakland residents who were over the age of 55 and had some kind of chronic condition. In October of 2019, we announced a $2.75 million commitment to fund new research to help prevent and mitigate the health effects of adverse childhood experiences, or ACEs. We're currently building out a national solution called Thrive Local to connect our members to community resources to help them meet needs such as food, housing, childcare, and other needs. We've developed a social drivers of health report to help employers understand the connection between where employees live and their health outcomes. So I think we've come to understand in our society a very important issue, which is that environmental factors actually have a bigger effect on health, probably substantially bigger than healthcare itself. And so Kaiser Permanente is endeavoring to engage that truth and understand how we can develop efforts to promote things like food security, housing security, healthcare security, decreasing adverse childhood experiences, and efforts like that. You asked about stigma. We are committed to helping people understand the importance of creating a culture of acceptance and support for mental health. That's why we launched our public health awareness effort, Find Your Words, in 2016, and you can find it at findyourwords.org. Find Your Words is one word. We're joining forces with others in the field to spark a national conversation about depression and other mental health conditions. Our intent is to reduce the stigma that can be a barrier to reaching out for help or support. We continue to invest in expanding content in Spanish and English, adding information about resilience and childhood mental health to the site just last month. We have multiple other initiatives on stigma. We have a partnership with the National Basketball Association focused on reducing stigma, improving resilience, and creating healthier generations. We have a groundbreaking initiative called Resilience in School Environments, expanding to 225 schools nationwide, which is really focused not on the kids as much as the staff, understanding that the staff are there every day with children who may have been traumatized and need to understand issues of trauma and how to work with children like that. So that effort is ongoing. We recently launched an online mental health and wellness training for KP employees and managers designed to help everyone at KP understand and identify the signs and symptoms of mental health conditions and to be able to assist someone, a coworker, colleague, community member, or loved one. And as you heard from Dr. Logan, we're making mental health first aid widely available to our staff.
Several questions were around our compliance with the mental health parity laws. And so I'm going to spend a few minutes on this slide. The three areas that we're focused on around this are that we've reviewed all of our benefits pursuant to the Act. We are in compliance, and we continue to monitor that as we develop benefit plans in the future to ensure that they are also in compliance. The second piece of this compliance work is operationalizing and understanding our utilization management to ensure that we meet the requirements of the law. And then last in this area, in 2014, Kaiser Permanente complied with the DMHC requirement to participate in the routine mental health parity, which includes worksheets. We've responded to all the requests. And most recent DMHC survey was issued in July of 2018, and as you heard previously, the next version should be out in the next month or so. This last item, I think, is appropriately connected to the question, not this slide yet.
Oh,
Same one, sorry. That's okay. Connected to the questions we received in August about the DMHC findings and the timely access to patient care for Kaiser Permanente, which we take seriously. The DMHC produces the Timely Access Report, which is intended to provide this information on all health plans. They use the Provider Appointment Availability Survey methodology. This includes having the survey conducted by an approved third-party surveyor called Mazars. They publish an annual report that covers all health plans, and we are a part of that application and participation in that survey. We also look to external entities like NCQA, HEDIS, and the Office of Patient Advocate, where Dr. Mordecai shared the recent summary of our successful rating with their most recent report. While we're pleased to see those results, we continue to constantly work on improving mental health, both reducing the stigma, improving access and care, ensuring that our primary care physicians have the tools and resources they need as a frontline defense to assisting our members and your employees. You also asked specifically about our approach in improving the deficiencies identified by the DMHC. So we did have deficiencies identified in 2012. They consisted of insufficient oversight and monitoring of access for non-urgent care. They did not find fault with the quality of care provided or the difficulty in assessing urgent or emergent care. We have made tremendous progress working collaboratively with the DMHC and their external consultant. Progress reports are reported on a quarterly basis with them, and we're meeting the needed deliverables by the following activities. In the first area around improved quality oversight, such as exceeding the established regulatory standard for first appointments, expanding internal capacity by increasing therapists and expanding recruiting efforts and focus, which I did spend a minute on earlier. Investing in treatment facilities, as Dr. Mordecai has outlined, by expanding and enhancing our treatment facilities, including the medical psychiatric unit at Fremont Medical Center and others that he outlined. The fourth area is by expanding our external provider network by contracting with qualified community providers when and where necessary to meet our access expectations and standards. On innovation options, we have a program we call Connect to Care in our telehealth, which has the ability for patients to communicate with their therapists from the privacy and comfort of their own homes, embedding behavioral health professionals in our primary care clinics and our emergency room departments for immediate access. Building a pipeline has been important in our ability to meet these needs around training opportunities statewide with over 300 trainees each year. We provide tuition assistance and grants to help train up to 1,000 new therapists across California over the next 6 years. And the last area of focus to meet these corrective action plans has been around reducing the stigma. And Dr. Mordecai spent a few minutes on the 2016 campaign that we launched. In the next slide, the last area was specifically around prevalence and utilization. So this slide will show all of the inpatient and outpatient services categories with paid claims between April of 2018 through March of 2019. So we're showing a 12-month period of time. CalPERS results are closely aligned with our overall book of business for the entire state of California. We've listed out the top 5 mental health diagnoses by prevalence and the overall number, and this matches exactly the book of business for Kaiser for California. We also outline the top 5 mental health diagnoses by cost, which also 4 out of the 5 match our California book of business. The one that doesn't is in your prevalence, just not in your top cost. We want to thank you for your time today, and we're happy to answer any further questions.
Very good. Thank you for the presentation. We do have a number of questions. Ms. Taylor.
Yes, thank you for the reports. So It looks like you've made some progress here.
Sure.
And I think that all of our health plans have issues with mental health. Well, number one, I had a question. You said you opened a mental health treatment center in downtown Sac. Is that an inpatient or outpatient?
It's an outpatient.
Outpatient, okay. And then I just wondered, we had a lot of questions for you, but I also kind of wondered on slide number 8, where you're working to help the social drivers of healthcare. I think I'm wondering. I see housing insecurity, food insecurity. Do you guys have a program to address the upswing in gun violence in schools and kids now having to do active shooter training for? I assume that would be a social driver as well. I wouldn't know. I'm not a mental health professional, but.
So we don't have a specific focus on children and gun violence, although that's a reasonable suggestion. We have made a substantial commitment to gun violence research to the tune of, I think, $2 million. So that's one way that we're trying to get a better understanding of the implications of that.
Is it overall gun violence or children and gun violence or all of it?
It's overall.
It's overall. Yeah. Okay, and then so you've done a lot to bring in more health professionals. I heard you talk about actually providing money for schooling for folks to. I know that's a big problem. So
yes.
I don't have Kaiser anymore, but one of the problems is when you call for health care or mental health care, nobody can take you. So I don't know if that was a problem that was occurring with Kaiser as well.
Sure. So the 2012 findings were around being able to provide timely, non-urgent appointments. So our emergent and urgent met the standard. So it was I need to call today and I need an appointment, and it was taking longer than the 14 days. The 10 days, et cetera. And so much of the focus of many of the tools that Dr. Mordecai laid out was a full package of addressing that. So it can't just be addressed by hiring over 1,200, therapists or building more offices. It's around making sure our primary care physicians have the resources to manage the member when they first present in their office. Expanding the capacity of the telehealth services to allow more clinician activity to happen without having to, be present. And so it's a full spectrum of work to meet not only the increasing demand, thankfully the increasing demand, quite frankly, of our members seeking that guidance, but also being able to manage it within those guidelines. And so that is the tremendous amount of work that we've been doing. Anything you would add? No. Okay.
So as another question I have that I've had members talk to me about is, so they go into their primary care physicians, talk about, hey, been depressed, I need to see somebody.
Right.
I'd say a couple of years ago, I haven't talked to this person for a while, they had said that basically their primary care physician was directing them, hey, go call our mental health. And then it was, like you said, how long to get in, who had an opening, because there was a lot of that. There was no openings. But it wasn't, it was sort of a detachment. But you still had to go through your primary care. So it felt like I think people were telling me they felt like, why should I go through primary care? Why can't I just talk to mental health?
Yeah, so that, and I'll have Dr. Mordecai talk a little bit about the primary care and the mental health. Our mental health is you go direct.
Okay.
You do not need to go through your primary care physician. We find that many of our members will present themselves. They don't want to say I need help, so
Right.
they won't call mental health directly. They may go into their primary care, and as an example, I had a doctor's appointment yesterday, for medical stuff. My physician asked me how I was doing, and I said, well, my mother-in-law fell and hurt herself and is living with me now. Not why I was there. I have the support I need, but she sat down and had a 10-minute conversation with me about the stress and anxiety of that approach. I was there for a completely different reason. That happens a lot. And so having the primary care physician understand the tools and resources available to members from the mental health perspective is really important. But our members call directly to mental health. There's not a need for them to go to their primary care physician.
Okay.
Do you want to?
And that's not new. So
Yeah.
Maybe the
There may have been a
person was- Maybe
misunderstanding.
they felt like
Right.
But they-
had to.
They need to, yeah.
Okay, thank you.
Great. Thank you.
Thank you, Mr. Rubalcaba.
Thank you, Mr. Chair. Thank you for the presentation. I appreciate you addressing a lot of the questions that were raised and issues. In the presentation, Dr. Mordecai, you spoke a lot about its integrated system, which we know Kaiser is, and I want to follow up Ms. Taylor's question, sort of was what you responded, Cindy, which was primary care physicians have, in one of the slides said, it has been identified as a gateway for the first, especially when there's chronic diseases, when there's comorbidity. We know that the mental illness coexists there too. But you mentioned they were trained. How are they trained to identify the need for mental health services, and what is the training, and what is the next step? How are they referred, or how are they addressed? Can you explain that process in more detail, please?
Sure. Thanks for the question. I do want to be clear. So primary care is not a gateway for us. So as we said to the last question, people can self-refer into mental health care.
I didn't mean gatekeeper, but
Oh, okay.
it means for many people who, some of the presentation was about how it's underreported perhaps or undiagnosed. So many members perhaps go to the primary care for
Right.
one reason.
Right.
And one of your slides and I think your presentation spoke about how they're trained. Primary care physicians are trained to be, I guess, not first responder, but the first point of contact.
Or first line. And
So how are they trained, and what is the next steps that they're trained to do?
Sure. So primary care doctors, like all physicians, are continuously retraining. There's for the physicians on this panel, we all know that we have to go through any number of hours of continuing medical education to maintain our license. Part of that training would be mental health training if they choose to take it. But then Kaiser Permanente specifically trains its primary care providers in terms of how it wants them to manage mental health conditions. And one thing I didn't go into a lot, but I mentioned, is what's called collaborative care. So collaborative care is not just, make your primary care doctors into psychiatrists, right? Primary care is actually a system of care that the primary care doctor can refer to so that people can get appropriate care and follow up, mostly for depression and anxiety. So there would be a team of specialists on the collaborative care team to whom the primary care doctor can refer, and that team knows how to track the patients, knows how to prescribe medications, knows how to do therapy-type interventions. So by way of saying, part of the training is to say, understand the resources that are available to you and use them when you detect that somebody's depressed. For direct training, we would say to them, you know that, as Dr. Logan said, 20%, some people would say 30% of people coming into your primary care practice have mental health issues. So these are not foreign issues to primary care docs. They see them every single day. And so working with them to help them understand, here are your first steps in terms of treating somebody who maybe they are open to a medication and that would be appropriate, or maybe they're not open to a medication. What are the steps you take for that? So I think trying to describe what it's like to be a Kaiser Permanente provider, you're tightly integrated into the care system and have opportunities to train and collaborate with your fellow docs continuously, essentially.
Here's a follow-up question. So does Kaiser keep any matrix or any reporting as to, from that primary care physician visit, how many are referred to further care for mental health illness or systems, and how many actually follow through? What is the follow-up that Kaiser does to ensure that people who are identified, say if they're presenting for diabetes, for example, and you mentioned the term comorbidity, so some people always have other systems in there. How do we follow up? How does Kaiser follow up to make sure they get the attention that's necessary?
So one of the keys to collaborative care is that it's a population-based approach, meaning you assign people into a population, and you say, this is our population of adults with depression in primary care, and we're going to follow them as a population. So much as we do with blood pressure treatment, right? You bring somebody in, you make a diagnosis that they have hypertension, you apply a treatment, and then you don't sort of let them walk out and see how they do. You follow up, right? You take their blood pressure again. So similarly with depression, anxiety, things like that, it's a matter of measuring somebody, making a diagnosis, making an intervention, and then reassessing. And if that intervention is not working, then you need to do something different. So again, this collaborative care is a population-based approach in primary care, and it's proven quite effective. And I think when my fellow physicians talk about the importance of bringing mental health into primary care, often they're talking specifically about this approach.
And I would just add, Mr. Rubalcaba, many of the reports that we produce now will show things like compliance with antidepressant medications, and things that are in what we call our chronic conditions report are around those diagnoses as depression. So there's HEDIS metrics that are followed that are reported based on that population care that Dr. Mordecai spoke about.
Thank you, Cindy. Thank you, Doctor.
Yep. Thank you.
Thank you. Mr. Miller.
Yeah, thank you for the presentation. I'm really heartened to hear the attention, the resources, the effort, because clearly some of the challenges and shortcomings are pretty obvious. So I don't really want to focus so much there as kind of a couple bigger picture comments and questions. One, the kind of adverse childhood events, the trauma, the prevalence, and the need for trauma-specific mental health professionals. I'd be interested in how you're addressing that. I recently was on jury duty for a little while, and it was potentially a trial involving some pretty severe crimes against children. We started off with a pool of about 160 jurors, and every time we got to the voir dire questions about, have you been a victim of childhood trauma, abuse, sexual abuse, domestic violence? It was incredible how many people had to raise their hand and were ultimately kicked out of that jury box.
Yeah.
And after 3 days, we finally got down to the last few of us who were left, and the case settled out. But it just reminded me that it's a lot more prevalent even than the numbers we have show, particularly in various populations. So that's my first question, is how are you grappling with getting trauma-specific people? Because they hit the workforce, but the underlying traumas are often as well established as children.
Well, we're certainly interested in hiring people who have trauma experience. Not all therapists do, but many more do now. I think the awareness has come up such that the training programs that we hire out of often have elements of that. And then, as I mentioned, we're doing the Resilience in School Environments is about making schools trauma-informed. Our own training programs have trauma modules in them, like I said, where we train over 300 providers every year. And you're right. I mean, as society has become aware, you recognize, and I certainly recognize, probably most of my patients have had some kind of trauma. And just general statistics say that only about 30% of people had no identifiable trauma in their childhood. Based on the Adverse Childhood Experiences study. And in some populations, some communities, it's far, far higher. So among the mental health issues our society is grappling with, that's a big one. And we know also that trauma contributes to incidents of suicide attempts and substance use disorder and depression and on and on and on. So,
Yeah, my second and kind of final comment and question is, it seems to me when I looked at your chart on social determinants and everything, the one thing that seemed to be a really conspicuous by its absence was toxic workplaces and workplace environments. Our members have been public employees, and when I came to state government here in California, way back during the Duke Mage administration, one of the first things that struck me is almost all of our approaches to human resource management, particularly when it comes to anything related to performance or behavior, were based on discredited 40 years old at that time models of behavior and models of using aversives, which society has figured out don't really work. Our prisons are now our mental health system. We now have wised up to, beating children is not the way to get them to be healthy adults and well-behaved children. Yet in our workplaces, we still have these old models of how you organize work, how you manage work, how you discipline and punish people to modify their behavior. And so many of the patients, I think, so many of our members who have mental health challenges, between the stigma and the practices in the workplace that actually exacerbate their anxiety, their depression, their behavioral issues. And yet the employers and the unions, I'm a longtime union official, don't really seem to be as interested in this as kind of a fundamental, it's not the immediate root cause if you go deep enough, but it's where things really play out in the workplace, and we're still, and so it seems to me that there may be a real potential for mental health professionals to help us as labor folks and human resources professionals to say, yeah, we can do better than these, old school approaches to, like we do an 80-hour supervisor training for all our new supervisors in state government. And I got to tell you, it's like, oh, it's, wow, more harm than good in many respects in terms of how we teach people that they're supposed to address behavior. So any thoughts on that as part of a bigger program to help our employers, our members, your patients, make our workplaces less of a contributor to the problem?
Well, I think it's an important comment, Mr. Miller, and I can see how that there could be another puzzle piece in there in our display, and you're bringing to mind many patients that I've seen who were in toxic work environments that were essentially making them have mental health problems, and it's a real challenge for them to sort of make their way through it. Often I was just trying to stick with them so that they knew they had an advocate, but there wasn't so much I could do to change their boss who was harassing them or things like that.
Well, and the two things that I would add for Kaiser as an employer, so the mental health first aid program that they put many of the employees through really helped. It wasn't addressing toxic work environment, but really making you mindful that your colleagues are in their own mental state that day. They're not all walking around thinking like you, or in a good mood or a bad mood, or in distress or not, but to really think about them, first as a human, and then, potentially that their behavior means something bigger. And so that's at least a step in the direction. I certainly know personally after that, I engage with my employees differently. I mean, I hope I don't have a toxic work environment, but, I engage with them very differently after those trainings. And then the second was also, reminded me of another passion of Bernard's was he launched an initiative called Speaking Up. And it took some time to really take off because it wasn't, are you sure that you really mean you want us to speak up? And it was about having a voice within your work if things weren't going right or there wasn't something that was fair or equitable or productive, that you were encouraged to speak up. And the organization provided guidance and training and insight for leaders and others on how to instill that in their employees and support it when it happens, because there's going to be varying degrees of who's going to speak up and what they're going to say. But those are two initiatives that we've launched internally as an employer that I think would help in those situations. Thank you. It was a great question.
Thank you. Ms. Middleton.
Well, first, I want to thank everyone who's a part of this panel and all of my colleagues. As you all identified, stigma is one of the issues that we confront. And by holding forums such as this and bringing attention to these issues, I think we make steps forward in eliminating some of the stigma that exists, and it's something that we need to continue to do. I was struck as I listened to the work that you're trying to do as to what are the issues around adequacy of staffing that you have in order to be able to address those issues. And I suppose I will start with the folks from Kaiser, but I think it is a much larger issue in staffing not only of MDs, but of support staff that would be able to help the MDs.
Yes, I think it was a great question. I think it really goes to the beginning of our presentation around just the severity of the needs versus the availability of therapists. And so our comprehensive approach has really been about dividing out what are all of the barriers to making more clinicians, the wide spectrum of clinicians available. From first providing, the funding in order to hire people, then how do you find them? How do you recruit appropriately when the demand is high and the supply is quite low? And so working upstream, as we've outlined around, supporting tuition reimbursement if that is a barrier for someone in order to get their, training and focus and building facilities. And there's a full spectrum of that approach that takes time and is difficult and challenging and requires a lot of things to work in a coordinated fashion. And our ability in a fairly short period of time for this type of work to be able to hire in a couple of years, several years, 1,200 more clinicians, and then to tap into our primary care physicians and emergency room physicians to shore up some of that need. As well as right now, we are currently contracting with outside providers to ensure that we are able to provide, the access that's needed. Would you add anything? Okay. Did that answer your question?
That's a
Okay.
good start. I want to turn to the Department of Managed Care. Do we have staffing models that have been defined for healthcare organizations in terms of what number of mental health clinicians they should have for a given population?
There are no specific standards with respect to numbers of mental health providers per enrollee population. In our authority, there are standards for physician to enrollee ratios, but not specifically to mental health. But on your issue of workforce development, one of the things the department has done over the last several years and some of the mergers that we have approved is to direct the health plans to provide money for workforce development, primarily through the Office of Statewide Health Planning and Development and their Health Professions Education Foundation. So there's money available similar to what other groups have been doing for loan forgiveness or scholarships for both mental health as well as the physician assistants, nurse practitioners, and the non-physician providers. So we are trying to support that work as well. And the governor also has put a lot of money into the budget this year for that same kind of activity.
And to complete the circle, are there things that we need to be doing here at CalPERS to ensure that there is adequate staff to provide the access to care that we want?
Sure, and I'll let Dr. Logan jump in also if she wants to. Some of the questions that we've been asking the external experts as we've been talking about this are novel ways of addressing some of these staffing issues. So one of the things that comes up often in mental health is telehealth. It is not a cure because at the end of the day, you have to have a provider on the other end of whatever technology you're using to have it be effective. But it cuts down on the amount of time that's not spent treating. It's also a venue for getting care that some people prefer over in person. It addresses the access issue in a different way, and for people who are really reluctant to come forward, it makes it easier. In terms of access, we are looking at a lot of different tools outside of the standard NCQA and HEDIS measures that typically are used to make these kinds of assessments. There are some novel ideas that have emerged that we are exploring or looking at as possible ways of getting a better read on access. But certainly it's an issue that's really critical.
Thank you, Mr. Chair.
Thank you. Ms. Green-Ross?
Yeah, so Kaiser, I'm pleased to hear all the things you're doing to be addressing the increased demand going forward, and the increased demand hopefully is related to the efforts to lower the stigma and get more attention to this issue. So my question then is, a lot of this stuff is in the works, and as you noted, it's going to take a while to get the number of actual staff that you need to have the ideal situation. What are you doing about the mental health needs of your existing mental health providers? Because since the demand sounds so excessive and all the things you're doing are pretty innovative, but it will take a while to implement, I'm guessing the strain on your current crew of providers is pretty excessive. I've heard anecdotally from friends who work in Kaiser, and that they're very stressed, that they can't spend enough time with patients, and so I'm just curious about how you're handling and supporting your existing staff who sound very strained, like we have in state government, where we can't get enough people and we have more work thrown at us.
Well, it sounds familiar from primary care physicians and especially young physicians. No? I actually really appreciate the question, because it's not one that I often get around this. We sort of forget about the providers that are really paving the way for innovative, care and treatment. So as an employer, just in general, there are a number of resources that are available to me. I'm not a care provider, so the stress on them is significant. As part of our engagement with that segment of employees, there's a lot around getting them actively involved on innovating care and how best we can meet that. So I think getting them actively involved in what that future care looks like, and I don't mean 10 years from now, it could be a year from now, months from now, on getting them actively involved in those guidelines. I think also, I feel that the significant, and I really do mean significant, effort around getting them the support, the members that they need to have additional clinicians, reduces that volume of feel of workload and that they're in it alone, and particularly building facilities that are dedicated to treating those members is making them first and forefront of what you provide to this organization and to our members really matters. And so having the space to be able to see clinicians, I know several years ago they were needing to share offices and rotate because the demand was so great. And so filling those availability for them to have dedicated space that is welcoming and that members enjoy, coming to evaluates that. And I would also say that we've encourage them to have a dialogue with their leaders, their managers, if there's something going on in their space that it isn't sustainable. If they don't feel like they have the resources they need to care for the members that are coming to see them, whether that's return time or office space or ability to connect with other providers, that they have their managers have been guided by the organization and supported by both the medical groups in both Northern and Southern California to really help those clinicians figure out how to manage this need. So those are a few areas. It's a unique question I haven't been asked before, so appreciate that.
Sure. Okay. Thank you.
Thank you, Mr. Ruffino.
Thank you, Mr. Chair, and thank you, Ms. Striegel and Dr. Mordecai for being here and answering some of the questions, especially from our office. Kaiser gets great marks, does great work for a number of its medical services. Why are its behavioral health services so vastly inferior? Is it due to lack of resources or an inadequate model for delivering mental health services? What do you think?
You want me to start?
If you want to start.
No, go ahead.
Well, I don't accept the premise that our services are inferior. As I said, and we're not trying to crow about it, but we're the only 2 plans with 5 stars from the Office of the Patient Advocate. There's 1 plan with 4 stars. So are we challenged by the issues facing all the plans? Absolutely. Are we moving towards a new model that we think can actually address the increasing demand in our society and the lack of providers? Yes, and that's what I tried to lay out for you.
What I would add in general, so I've thought quite a bit about this. We have spent quite a bit of time talking about mental health services with many employers, very different than diabetes care or cancer care. I think the topic is emotional. It's mental, but it's emotional. I think there are a number of factors that influence more intense structure and focus around it. And where I come around to on a regular basis is that, I see as your objective, the board's objective and CalPERS' objective is for their employees and ultimately our members to have, the best possible care around all medical conditions, including mental health, and have access and service that meets their needs. And where I come around to is I can honestly sit here and so would Dr. Mordecai and say our objectives are aligned, that we are deeply interested in meeting and quite frankly exceeding the needs of our members around mental health. And everything we're doing is in order to get there. And it is a journey. It is not reflective of our lack of commitment or desire or interest in actually leading the nation in how to best care for members who are in need of mental health. There's a lot of factors around, demand and provider availability and stigma that comes into account that makes this work even more challenging than, say, diabetes or cancer care. But we're as committed to mental health as we are to those.
One quick follow-up. We all know, we have heard of that. We understand that you were cited for violating, a variety of state mental health laws that back in 2013. but have not yet successfully corrected all of those violations. Why is it taking so long to remedy these violations?
Yeah, no, it's a great question. There were 4 specific findings. 2 of them were corrected, and I apologize, I don't know the timing, but they were corrected relatively soon after. The last 2 were around, continued effort around access and service, on making sure that members can get it in a timely manner. So that's going to require system changes, which have happened. It's going to require hiring of staff, which has happened, but certainly there's more to do. And so they're particularly around staffing up and beefing up the system to support it, and will take some time to get there. We feel very confident that we will be there, and are working closely with the external consultant to ensure that we're meeting milestones, and as were shared earlier, that we have been. This is not an issue or an area that we can solve overnight. We can't just throw more money at it. We can't throw more effort at it. We're doing the things that we feel are the most important. They just take some time to implement.
One other quick to the Department of Health. I know that you guys hire, I think I understood, an outside monitor in 2017 to monitor that work. Thus far, have they gone meaning Kaiser, have they gone a DHMC investigation that documents that it has successfully resolved or all the violation committed? Or can you comment on that? Or if not this specific, but in general, can we be assured?
Certainly. The department, as part of the settlement agreement, required Kaiser to contract with the external experts to help the plan address the deficiencies around their quality assurance program, and to be able to effectively identify and address issues. That monitor or consultant really, has been working closely with Kaiser and reporting to the department on a quarterly basis on their progress. And as I said earlier, they are meeting all the benchmarks and milestones of the settlement agreement. And then Dan's shop will be doing a follow-up or a routine survey next year or this year? Correct.
It's in its current process.
Okay.
We have finished our on-site portion of that survey.
Yeah, just to, just do our own due diligence on how that is all working, so.
Thank you. Thank you, Mr. Chair.
Thank you. Ms. Pascal Rogers.
Thank you, Mr. Chairman. Thank you very much for your presentation today. The collaboration and partnership is encouraging, and the additional staff that you'll be hiring is encouraging. What I'd like to hear is, are you working with different statewide groups or local groups to identify that reflect the great mosaic and need of our state in trying to build your applicant pool? Because as an Asian American, when I was growing up, if I went into the mental health area, my parents would be like, "You're not a lawyer. You're not going to be a lawyer." So, but I know that the needs of our state are very different.
Yes, very diverse.
And so very diverse, what are you doing to encourage a strong applicant pool that reflects our great mosaic?
So thank you for that question. As part of our efforts to increase the training that we're already doing, we are working with a number of the professional schools out in our state, and we are always interested in the diversity of our workforces. As you probably know, Kaiser Permanente has won many awards for being one of the more diverse healthcare entities. But so we're actively going out and meeting with those schools. I think, behind your question is an important thought about, well, how do we go even further? Are there ways to get into the high schools, for instance, and get people interested, even if they have to tell their parents that they're not going to be a lawyer? And I think that's territory we haven't gone into yet, but probably should. And then, of course, we've devoted, as we said, tens of millions of dollars to allow our own employees who want to become mental health providers to do that, so that they're not facing a huge tuition burden when they're wanting to become something that we would like them to become, and to hire them. And we certainly hope that we will draw from the very diverse pool of talent that we have internally as well.
Mr. Chairman, I have a follow-up. Thank you. So I believe that children don't know what they can become unless they see it. So I do see you in the communities a lot. I would encourage you, though, to go to the schools, because if there's a kindergartner out there who is seeing what you do and you're saying it in their language in ways that they can associate help, you are encouraging people. So it's great to sponsor community events. It's super when you can actually be very thoughtful about where you're putting those resources and how you're helping the community.
Yeah, that's great. Thank you.
Thank you, Mr. Chairman.
Thank you. Ms. Taylor.
Thank you, Mr. Chair. I want to thank you for both coming and answering our questions. And I really appreciate DMHC and our staff for putting this together. This was a great presentation. So one of my concerns is Kaiser is an integrated health system. So these questions are for our staff. As a user of one of our other HMOs, I find that while there may not be complaints about these other health systems, our other providers and our other insurance carriers are also lacking when it comes to mental health. I'm wondering if Dr. Logan and Mr. Molds, what we are looking at in terms of that. I know the only complaint that came in was about Kaiser.
Yeah. So we have queued up for next month similar presentations and discussions with the three other large health plans that we contract with, United, Anthem, and Blue Shield of California. So we're this isn't a Kaiser unique exercise. We're doing this across the board. One of the things that you're going to run into when we start having those discussions is the models are very different, as you pointed out.
That's my issue.
Yeah, and in particular, one of the things we'll be talking about when we start talking to some of the other carriers are the challenges that come with carve-out mental health plans and integration. So again, Kaiser's model very different. The carve-outs in a lot of ways make MPIA compliance, mental health parity compliance, easier, but they create other challenges having to do with referrals and the seamless integration of behavioral and physical health. So we'll be talking about that more with those plans next month.
Okay, so that's good, because I didn't know we were going to do that. Because my concern is that carve-out situation where the insurance carrier is okaying you to go to mental health, but the access is not there. There's just not enough mental health care providers. And you can go through lists and lists and lists before you find one with an opening. And then if you're looking for any kind of urgent care, even if your insurance covers a portion of that, which is completely different from an integrated system, you're paying for a large portion of that outpatient and or inpatient care because they're private institutions.
Sure, I can kick part of this to DMHC because the part of MPIA is supposed to be parity along, financial copays, cost sharing, and so forth. So that shouldn't be happening in theory. They can maybe comment on that in practice.
So as we were discussing earlier, quantitative treatment limitations require health plans to not apply more stringent cost sharing to mental health benefits when compared to medical surgical. So that would be an issue I'd like to know about that we may not be aware. We did find, like I said, 7 health plans that were non-compliant in this area. We required them to go back and re-review claims and reimburse enrollees appropriately. We will continue to assess their compliance through our routine survey process as we move forward. But if you have a specific incident where that's occurred, I'd like to know about that so we can look at that as well. On the urgent
we can
side.
talk later, but I think one of my concerns is a lot of people would, rather than go ahead and pay for the health care, not take it. And that can be a problem. And I know that that's not supposed to be the case, but it was the case. And maybe it was before the Affordable Care Act. I can't remember. But it prevents people from seeking mental health care because of that.
So I think you're speaking to access specifically.
Yes, access, yes.
And so access, as Shelley was alluding to earlier, we review that in a couple of different ways. Our annual network review process, each health plan is required to submit their entire networks of providers to us on a yearly basis. We assess those against the current laws to determine if they're adequate. As Shelley also was speaking about, the capacity is only specific to for ratios are only specific to PCPs, and in the physician world, it's one physician as a group to every 1,200 enrollees. So we don't have specific capacity ratios for mental health providers. We assess the health plan's annual network data and we apply it across all health plan data to see if we find them to be an outlier, and we push that health plan to come more into the norm of the other providers without having those specific laws. Many health plans have responded by adding more providers in whatever specialty type it might be. So,
could I just add something to Dan's comments? Even though a health plan may contract with a behavioral health plan to provide mental health and other behavioral health services, the health plan is still responsible for all the actions and activities of its delegates. So you're still going to hold Blue Shield accountable for whatever its delegated, behavioral health plan is doing. The other thing I just mentioned again is that if you or somebody is having problems getting access to care, that they should call the help center, and we can help facilitate a resolution of that problem. And we do get good results. So.
All right, thank you.
Very good. Thank you. Seeing no other requests, thank you all for a great presentation, very enlightening. We do have a number of requests from the audience on this item, so as soon as you take your seats, we'll bring them up. Thank you again for being here. So we have a number of requests to speak. The first two I'll call down are Sarah Sorokin and Fred Seavey. Please come down to your right, my left. The microphones will be on for you. You'll have up to 3 minutes for your comments, and please identify yourselves for the record.
Hi, my name is Sarah Sorokin, and I'm a marriage and family therapist working in Kaiser's Napa Solano region. At Kaiser clinics across the state, we're routinely unable to deliver timely, clinically appropriate care. Patients in my region typically wait 1 to 2 months between individual psychotherapy treatment appointments for depression, anxiety disorders, PTSD, bipolar disorders, and other conditions. These wait times are completely inconsistent with professionally recognized standards of care, which is weekly or biweekly appointments at the beginning of treatment. As a result, patients experience prolonged or worsening symptoms, some needing to access emergency or inpatient care. The root problem is the understaffing of Kaiser's mental health services and the inadequacy of Kaiser's external networks of contracted therapists. In response to understaffing, Kaiser has cut in half the time spent on initial diagnostic assessments, and instead of conducting them in person, Kaiser has begun doing thousands of these shortcut assessments by phone. Therapists must try to diagnose whether a first-time patient has a major depressive disorder or PTSD or bipolar disorder during a 30-minute telephone call with someone they've never met and cannot even see. This is not an appropriate use of telemedicine in psychiatry and can lead to misdiagnoses and improper treatment plans. Many clinicians are especially concerned about our adolescent patients, many who wait 4 to 8 weeks before they're actually first seen by a therapist. This is because Kaiser directs therapists to do a 30-minute telephone call with adolescents' parents within 10 business days of the appointment request and counts this call as meeting the state's timely access requirement, even though the adolescents were often not even talked to. Given the tripling of the suicide rate among youth across the U.S., reported last month by the CDC, this is risky. We've raised these concerns with Kaiser and the DMHC, but it appears that neither have taken substantive action. In closing, I'd like to say I support your efforts to investigate the adequacy of Kaiser's mental health services. Patients' well-being and lives are in the balance. I and my colleagues would be happy to assist you however we can. Thank you.
Thank you.
Good morning. My name is Fred Seavey. I'm the research director at the National Union of Healthcare Workers. Our members include 3,500 psychologists, licensed clinical social workers, marriage and family therapists, addiction medicine counselors, psychiatric RNs, and other therapists who deliver care to Kaiser's members at more than 100 clinic sites, emergency rooms, call centers, and other facilities across the state. During the past 9 years, I've worked with our therapists, patients, family members, the DMHC, advocacy organizations to try to improve Kaiser's health services. You know, we're delighted that the committee is examining more carefully the behavioral health services provided by Kaiser and other health contractors of CalPERS. And similarly, we're pleased to see Kaiser and the DMHC here. You know, although Kaiser is well known for providing many top quality medical services, historically it's understaffed and under-resourced its behavioral health services, which lead to outcomes that Sarah described. Care that falls beneath professionally recognized standards and often violates state law. Our experience over these last years, these 9 years, calls on us to caution you against relying on the DMHC in terms of its capacity to adequately evaluate and monitor and enforce laws. This grows out of our experience. You know, there's been references here today. In 2013, the DMHC cited Kaiser for, quote, serious and, quote, systemic violations of state law. Those violations have still not been remedied. And these were very serious violations of depriving thousands of patients of timely access to care, violations of clinical appropriateness standards, quality assurance protocols, the provider network adequacy requirements, et cetera. We're very concerned that this is our state's regulator, our state's largest provider of mental health services. Why haven't these violations been corrected? Secondly, we have concerns about the DMHC's lack of transparency. The 3-year oversight process, we've requested records through the Public Records Act regarding the monitor. They've refused to provide any of those documents during this 3-year oversight process. Thirdly, we're concerned about the lack of accountability of the DMHC to the public. During the past year, we filed 13 additional complaints. Each of these is documented by internal records, including some emails from Kaiser top officials describing and admitting about their inadequacy of their own care. The DMHC has failed to even indicate to us whether it's investigating these complaints, whether it's resolved them, what is the disposition of the complaints. So finally, I just want to reinforce, again, our support for this effort to probe into the behavioral health services delivered by your health plan contractors, including Kaiser, and secondly, caution against relying on the DMHC. We urge you to develop your own rigorous systems of audits, plan monitoring, and enforcement mechanisms of your health plans. Thank you.
Thank you. The next two are Ryan Beeston and Larry Woodson.
Good morning. I'm Ryan Beeston with the National Union of Healthcare Workers. I'm the legislative coordinator. I would just like to make a quick point of clarification around the Office of Patient Advocate scorecard. The methodology is flawed in that it only considers 6 performance metrics related to behavioral health care. None of these metrics measure patients' wait times for routine mental health treatment appointments, which are the services received by the vast majority of mental health patients. The only appointment wait times considered by the OPA are for a very small population of patients, namely those who have been discharged from a psychiatric hospital. Furthermore, the OPA bases its scores on HMO's self-reported administrative records, whereas the DMHC performs the in-person investigations, a random sampling of patient charts, and agency-initiated data collection. You have the handout which lists the 6 criteria, and you can see that they don't reflect the ongoing challenges at Kaiser. Thank you.
Thank you.
Larry Woodson, California State Retirees, Chair of the Health Benefits Committee. Thank you, Mr. Chair, for the opportunity to comment. On behalf of CSR, I'd like to thank the CalPERS board and staff that have been, and particularly Dr. Logan, for shining the light on this topic on mental health needs and services. And creating public dialogue. I think it's or it will benefit our members and help reduce stigma. I gave public comments in August regarding and drew attention to Kaiser's violations of the Mental Health Parity Act, timeliness of access issues. It's encouraging to hear some of their progress. It's also discouraging to hear from some of the public commenters of the actual therapists that it sounds like there is still a real divide, and I hope that both sides can reach agreement in this labor strife, because that is a huge factor in and will impact the provision of effective services. And then lastly, I'd like to, and we're looking forward to the DMHC report when it comes out in 2020. Finally, regarding Dr. Mordecai acknowledged the impacts and social and medical conditions on that they can have on mental health. And to that end, and this may be a little off topic, but it's something that CSR has been very concerned about over the last year and a half. We would encourage Kaiser to begin to provide supplemental and personal services pursuant to the Chronic Care Act and regulations that were adopted by CMS, federal CMS, for the Medicare Advantage plans. The most recent information I just got from all three plans that are our carriers, they're really not stepping up. But there'll be more on that later. But modifications to the home are something they could provide that's preventative. Handrails. There's limited in-home support services. They're not stepping up on any of those, and we'll be continuing to push. We've had some discussions already with Dr. Moles, and we'll probably be discussing them in the annual stakeholder review meeting. Thank you.
Thank you. Okay, before we move on to the next agenda item, we need to take a 10-minute comfort break for the court reporter and the rest of us. So we will reconvene at 11:30.